fracture. I'll post this situation 1. It's a 12-year male, and this is the fracture. Okay. And this is the treatment. This is the fracture line, and this is the treatment, and 1 month follow-up. Let me know your comments. What do you think? This is a good fixation, bad fixation? If bad fixation, what could have been done? Please type in your chat boxes. Yes, pediatric DHS could have been another option. Yes, Ajmal, it's not a stable fixation. I agree. Yes, Sushant. So I think ideal would have been if this purchase was not good on table, the surgeon should not have hesitated crossing the physis. And since the fixation was not good, probably spica was not given or immobilization was not given. That is why the fixation has given way and there is a varus alignment as mentioned by Ajmal, right? So now the things continued, and 3 months later, this was the scenario. So now what? Now there is a further collapse. Articular trochanteric distance is gone, and X-ray in the lateral view also shows frank non-union here and here. So now what will you do? This is the situation in which child came to me. Yes, screws needs to be removed, but union also needs to be achieved. So what will we do to achieve the union?
Valgus osteotomy, sir.
And fixation?
With pediatric hip screw? Pediatric hip screw or blade plate?
No, the thing is you will have to fix 2 things here. One is you have to fix the fracture neck femur, plus you will have to fix the valgus osteotomy. So how are we going to do that?
Pediatric plate or hip screw, sir?
Pediatric plate. Pediatric plate means AO proximal femoral plate you are mentioning, or some other plate you are mentioning?
Pediatric AO plate, sir.
But AO plate has one disadvantage. It does not give you compression at the fracture site because all are locking screws.
Pediatric DCS. DHS, sorry.
DHS. Okay, so that is an option. And how will you fix fracture femur? Will you put any another screw?
Yeah, another screw, sir. Derotation screw.
Okay.
Then we screw with derotation screw. With
and where will you do valgus osteotomy with DHS?
Below the level of subtrochanteric, at the level of subtrochanteric levels.
Okay, so let us see what I did. Okay, so I think that options we already discussed. This is the size of the child, right? 6 months, my doctor told that fracture is not uniting. Mother felt that the child should be well fed. So that child became about 82 kg. So do you think pediatric DHS is good option for 82 kg baby?
No, definitely not.
Right. So that information was not there with you. So now with this boy, what will you do?
Sir, how old is the fracture, sir?
Now it is about 13 years old.
No. How old is fracture?
6 months.
Sir, I feel valgus osteotomy with lateral plate fixation should be fine here.
So how will you fix a fracture neck femur then?
Sir, blade plate.
Have you used blade plate?
For the adults, I have used it.
Again, blade plate is good option for osteotomy, but blade plate will not give you any compression at the fracture site.
Yes, sir. The technique which Sandeep Vishwadhan sir had actually shown in one of those lectures, in which he is using a normal 1/3 tubular plate only, and then
that is for fixation, not for valgus osteotomy.
Okay.
I agree.
But the weight of the patient.
And with this 80 kg, I don't think that your 3.5 or 4.5 DCP is going to hold enough.
Okay, sir.
Okay, so we have to discuss a lot of more cases. So I'll just show you what I did. See, I had pediatric DHS ready, but I could negotiate adult DHS easily in this time. Okay, so now you can see the adult DHS central screw. Unfortunately, I couldn't pass a derotation screw, which should have been done. But valgus was done at recitrocantral level. And you can see there's a lateralization of the shaft, which ideally should be done. So all the principle of the osteotomy have been followed. The adult DHS fixation was done. Child was immobilized with derotation boot for about 1 month. And we haven't used any bone grafting, and we haven't used any fibular graft. And this is 6-year follow-up of the same child. And this is the clinical result. Now you can see the child has pulled down and he is absolutely normal. Right, so fracture neck femur is one of the most common area for non-unions. And the only treatment, if you look at the literature for fracture neck femur non-union, is a valgus osteotomy. The only thing is situation every time is different, but the treatment generally remains same. So now let's look at the second situation. Any questions? Okay, so we go on to the second situation.
How much valgus, sir? How much valgus, sir, in valgus osteotomy?
So 135 was the total angle at the end of the surgery. I think when we began, it was about 95 to 100 degree. We converted into 135 degrees at the end.
Okay, sir.
You put the screw in the center of the femoral neck, and then if you apply 135
Okay,
plate, you'll automatically get that angle. Your vertical fracture site will become horizontal, and your shear force will get will converted into compression forces. So this 7-year male fell and had a fracture in November of 2019. So first question, how will you treat this fracture? Please type your answers. This is a fracture. I must get
CC screw fixing.
deep spica in a nasal fracture. Yes, you have to keep a very, but without lateral X-ray, I will not be very comfortable. And fracture femur, if it is a 1, 2, and 3, I will be more happy to do some fixation with spica rather than going for only spica. If it is type 4, I wouldn't mind spica. Yes, CC screw. Which CC screw will you use?
4 mm.
4 mm. Yes, I think, and here the technique of Sandeep is useful, right? So here technique which Sandeep has showed when he uses side plate with this is really handy. But unfortunately, this child was treated like this. So do you approve of this?
No, sir, it's varus fixation and.
No, there's no virus. I don't think there's any virus.
Okay, sir.
But if you look at if you look at the first X-ray, here it was absolutely undisplaced, and while putting the DHS screw, I think the head has rotated. If you see both the views, head appears, the distance appears more, and this is too big. This has actually distracted the fracture, right? And a child was not stabilized. It did collapse, and this is the X-ray immediate post-op and at the end of 1 month. So what do you expect here?
Shortening with abductor lurch.
Shortening with abductor lurch. Yes, Sandeep has picked up very well. Implant is too large. Okay, so this came as a surprise to the operating surgeon, 3 months later, he came to me with flexion deformity and significant movement restriction. Okay, and this was the picture. So now what? Yes, now what? What will you do for this?
Sorry for the repeated same answer. Small blade plate can help here, as the DHS has removed a lot of the bone stock. Blade plate will help here, I think so, sir.
So do you think only blade plate, or you would want to use
With fibula shunt graft? With fibula shunt graft.
Yes, so I think that is probably a very correct answer. So this was the flexion deformity, and the movements was this presentation. Okay, so let me take you through what I did in this case. So we removed the side plate first. The DHS screw was like this, which was again I removed it and put a guide wire in the inferior part of the neck, because at that point of because that was the area where I wanted to put a fibula graft. So after the channel was created, angle blade plate chisel was used, and then fibula was harvested, and it was put there. I chose angle blade plate short of IFICS, but when I tried to abduct, everything came out. So fortunately, I had a longer blade plate. So I put the blade plate all the way to the subcondylar bone. I had a good hold, and then I did a valgus 135 degree, and that is how the fixation was done. Somewhat retro anti-version was slightly more, but that was the best fixation I could do. And you can see I have immobilized it with spica. And this plate, which is fork plate, which is an old AO design, available in copy in India, has a one advantage that you can put a screw here. Because this was a little fixation, I was not very comfortable. I could manage to put one screw here so that I had some better hold in the proximal fragment. This is 2 months post-op. Fraction neck has united, fibula is consolidating well, and the head, as expected, has gone in avascular necrosis. This is a 1 year follow-up. Head is slightly collapsed, but everything has united. Trochanter I have already fused. Posture improved, flexion deformity improved, movements improved. And this is how he walked. There was a little limp. At this point of time, there was mild protrusion of implant in hip joint, I thought. So we removed the implant at about age 9 months, 11 months post-op. After that, this is the latest gait, December 2021, and now he has almost normalization of the gait. He is short by about 0.5 centimeter at this point of time, but he's probably shortening is good. He's going to grow more, and is a very good functional result. Yes, Sandeep, you want to add something?
No, I think it's an excellent result that you have shown. Everybody has to realize that it can become a big implant and it cores away a lot of head. So please avoid from using that. If you are using only
Sandeep, we are not able to hear you properly. I think we'll go to the next case. Sandeep,
Sir, I have a doubt.
yes, please go ahead. Tell me.
Sir, here the fibula shunt graft was kept below, and blade was passed through above, no, sir?
Because what happened was, I thought if I use that superiorly, fibula, I won't be able to get any hold there. So that is why the area in the shaft and the lateral cortex was a very big halo, and the bone on the greater trochanter side was better for the side purchase. That is why it was done reverse. I would have loved to do that, but you see, DHS was put absolutely in the center, and on table I found the superior bone was probably better than the inferior bone. So inferiorly, because I had to anyway, both of things had to go through the on the upper part of the DHS hole and the lower part of the DHS hole. So the treatment is same in both the cases, but the technique is very, very different, and this will require all the time improvisation, and that is why I have operative operative steps.
The screw below the blade plate, below the blade is going through the fibula, sir.
No. It is in the shaft.
Okay, sir.
But it may go, even if it goes, it doesn't make any difference.
There is no issue, sir.
Yeah, there's no issue there. So it doesn't. Okay. So this girl, she was daughter of a construction worker, and she fell from a wall being constructed. It is about 10 feet old, tall wall, and she fell. And bilateral fracture neck femur was there. She was operated on day 2 with single screw. Hip spica was given for about 1 month. And at 1 month, with the surgeon thought that it is enough. So he removed the spica and allowed the child to walk. Child did not walk for about 1 month, went back to him, and then he took this X-ray, and then he referred to me. So this is about 4.5 years old girl with a bilateral fracture neck femur. You can see there is an avascular necrosis here. This is a typical type 3 avascular, type 2 avascular necrosis, which is generally seen only in children. So now what? Child is not able to walk. It's a bilateral fracture. The screw is going out on left side, but seems to be holding on the right side, and bilateral painful hip movements. Sorry, I am unable to hear you well.
The threads of the screws are in the fracture, sir.
Yes. So what will you do? This is the situation. Yeah, we all see that, but how will we remedy this?
Pediatric DHS with the derotation screw and gastrostomy for the right one. Right one we need. Actually, the screws for the right one, sir.
Screw for the right one, and for the left?
For the left one, pediatric DHS and the subtrochanteric gastrostomy.
See, at 4 years, pediatric DHS is also slightly larger.
Yes, sir.
Yeah, so pediatric DHS is not an option, I would say.
Sir, I feel for the right one, we can go ahead and replace the screw and put in the that 1/3 tubular plate can be fine for the right one, sir. And and for the left side, sir, we can go ahead. We can remove that CC screw, and next we can use a fibular stud graft and fix it with a 1/3 fibular plate.
Fair enough, we can do that. So will you do in same sitting or would you stage it?
Sir, I would like to do it in the same sitting only, sir.
That's too much of a surgery.
Okay, because considering that the child is 4 years old, one time we are giving him anesthesia.
But child is not earning anything. Child is not required to earn anything. Child is not required to go to school.
Okay, sir.
I think such cases you should give your 100%. And when you do bilateral, a rare case which probably never seen in life, this is first bilateral femoral neck non-union.
Okay, sir.
So I think these small practical tips are very important. You should go with a fresh mind. You can always stage it about 1 week, 2 weeks, depending on your comfort.
Okay.
Let everything pain and everything subside on one side, and then take it on the other side with fresh mind and fresh hands and fresh OT staff and everything.
All right, sir.
First and most important thing which you have not asked is lateral X-ray. Here you can always take a lateral X-ray, right? You know
yes, sir.
What's happening in lateral X-ray? You always take lateral X-ray everywhere. Why not here? Okay. So I would have expected, show me lateral X-ray, and this is how I show you lateral X-ray. Now, lateral X-ray gives you one more information, that there is an avascular necrosis on the right side also. This is the left side also, type 2 avascular necrosis. Radcliffe classification, type 2. So does it change any treatment, or it's the same treatment? Yes?
We may need to add fibula stud graft to right also.
But your data will bring in any vascularity? See, dead fibula can only help you to increase stability if there is a bone gap. But if there is no bone gap here and the screw size is also reasonable, it's not like a previous case where the screw has eaten up the whole head, whole neck rather. Okay, so I think it's a difficult case for everybody. Similarly, it was for me also. But when I assessed this child, I found that child had a significantly less pain. So what I did was, I just put the child in spica. I thought child is pretty young, and let me just put in spica. So this is the immediate post-spica X-ray. And this is the X-ray after removal of the spica. So what do you feel? What is happening here?
The fracture is consolidating and the vascular necrosis is dead.
It's going, right?
Yeah.
Let's see further what happened. This is the lateral view. Right? The screw which on left side was appearing out is now appearing in. Right? Okay. This left screw was always appearing outside here. If you see the here, this was looking out and now it is looking in. Okay. Both the views. AVN is also improving. Further follow-up. And this is functional result. And this is the final follow-up. Right? So in kids, sometimes you don't need to do anything. They have an excellent union power, and you can just wait. This is an anecdotal case. I have already reported this case. It has been published in Indian Journal of Orthopaedic. This is the only reported case of bilateral fracture neck femur non-union in a child with bilateral AVN. This is the first and only case reported in the world literature.
Sir, I had one doubt, sir.
Please.
Sir, when will we decide not to touch this case? I mean, looking at the X-ray, the PVH anterior-posterior view and the lateral view. So the first X-ray, when the patient presented to us, looking at that X-ray, we thought that we should be going ahead doing a 1/3 fibular plating and all that. So when should we make a judgment, or when should we decide that we should just give it some time, let it be like that, and then go in?
So if you read the article, I have discussed that. The only thing which was in favor of this child was that child, while non-weight bearing, had a reasonably good movement. That means I thought the implant was holding. And I thought, let me just give, because bilateral surgery is too much for even me. We have some experience in this fracture neck femur, but bilateral implant choices are not that many. I just simply thought that let me just give a chance of about a month or so. And by that time, if the child doesn't respond, we'll do it. It was just, I cannot tell you this. This was sixth sense, Just that told me that why not give a plaster trial for some time.
Okay, sir. Okay.
I don't think I can give you any scientific reason because there is not much of literature on bilateral fracture neck femur. There have been only 20 cases of bilateral fracture neck femur reported in children till date. Right? But when the child is young, you feel that biology can help and when you feel that still the implant is holding. So that were 2-3 things which were in favor, but I could have failed. I just got lucky. So that is one most important thing from this. But this is a surprise, and I've never been earlier reported. Conservative treatment for non-union fracture neck femur has never been mentioned anywhere. So I thought of just sharing this anecdotal case. This is absolutely anecdotal and lucky case, and this does not have any further message, then being this one of the rarest of the rare case. Okay, so what others do, primary, I have already shared our experience in the fracture neck femur. And there is been report of primary valgus osteotomy from India only. Only 2 centers, both of them are India, and these are the statistics which they have mentioned. Unfortunately, their way of fixation, I did not like it. And I feel that primary valgus osteotomy is definitely a overkill. In a meta-analysis by Hosalkar, they found that the primary valgus osteotomy is not of great help. This paper from China mentioned that open reduction in internal fixation, if the child presents after 24 hours, will significantly reduce complication rate and improve union rate and decrease avascular necrosis rates. Okay. Any question, or we move on to femur shaft? Sandeep, are you there?
Yes, I am there. Can you hear me?
Yeah, now we can hear better. I have opened your presentation. Which are your cases? Is it fracture neck femur? Then we can continue with your cases.
No, only shaft femur. Shaft femur.
Okay, so I'll do one shaft femur and then we'll take your cases. Okay. Be there. Okay. So facts about shaft non-union in children is, this is from the 8th edition of Lockwood and Green. The non-unions in pediatric femoral fractures are rare. Femoral fractures account for only 15% of non-unions in children. Tibial fractures are slightly more common source of pediatric non-unions. And non-unions generally occur in adolescents, infections, when there's a segmental bone loss or a severe soft tissue loss. But even if you have a segmental fracture loss and significant soft tissue injury, still children can throw good callus and non-unions may not be very common. If you remember, I have discussed delayed union and non-union in tibia as well as fracture shaft femur in a pathological case. There was a case of Ehlers-Danlos syndrome, and Sandeep was also there, and we discussed that hypertrophic non-union was there. So we are not going to discuss that case, but we are going to discuss a different case. This is the only literature which was quoted in Rockwood and Green. I could get hold of this paper, and if you look at this paper, all the patients had some intervention. Open reduction, plating, or external fixation, right? None of the patient had nailing, and that is why we have always maintained with you that nailing is one of the best treatment for fracture, femur fracture. If the circumstances allow you to do nailing, that is the best treatment, right? Let's go on to the first treatment. This 3-year male fell with a trivial injury and presented to a young and dynamic orthopedic surgeon with this X-ray. And suppose this child comes to you with a closed injury, what will you be doing for this child?
There should be some disease, pathological fracture, sir.
I don't know. There is no history at this point of time. This is the first fracture.
Sir, another.
No, we don't have any another view. Unfortunately, the treating surgeon did not take another view, and I inherited the case slightly later.
We can try conservative management, sir. If the angle is not present.
So the thing is, you feel that this is not a normal thing, right? So the first thing what we should have done is dig into history and maybe investigate, at least do a skeletal survey and find out that what we are dealing with. Unfortunately, this enthusiastic orthopedic surgeon didn't investigate the child, and he treated this child with 10 nailing. Right? So everything done well, 10 nailing. I think probably outside the skin he has kept the nail, and he has given a spica. So what do you think will happen?
Entry is near the physis, sir. And
it's pretty close to physis, but I think entry is somewhere here. I think if you look at the entry is all the way here. The only thing is superimposing the physis. Yes, Sandeep.
Premal, can you? Yeah, this kind of nailing is called open run and internal decoration.
Yes, absolutely. He's saying this is open reduction and internal decoration.
Earlier he used to say OIFICS, sir.
Right. So I think it is just it is a bill making surgery. It is neither holding anything. It is neither treating anything. And I think as it is very well known, this is a day one failure. You know that this cannot hold on. This cannot unite. But in children, very rarely things can differently happen. So you see the entry was here. You see there's a newborn formation here. The entry was all the way there. And surgeon thought that fracture is united, so he removed the spica and he removed the nail also. Probably it was kept outside. The parents are not aware of. And the moment the child stood, this happened. So a few weeks later, child was not walking, so parents went to the orthopedic surgeon and he took an X-ray and he referred to a senior orthopedic surgeon. The senior orthopedic surgeon, he was back to square one. Senior orthopedic surgeon thought well, and he did a skeletal survey. Unfortunately, there was nothing much in the skeletal survey, and he came with a diagnosis which was very rare. So the surgeon wrote clinically congenital pseudoarthrosis of femur, surgery, chances of success are less. So with this situation, what should we do? Let me know your answers.
CT and MRI, sir.
When X-ray is normal, what will CT give you?
Sclerosed dents or
that you are already seeing on the X-ray, right? So more information, that information, will it change your treatment? So I think one important dictum of getting any investigation is that you feel that if that investigation is going to change your line of treatment or significantly contribute in planning the treatment, then it is a worth investigation.
Sir, can we hip spica for some time?
Sorry, come again.
Sir, can we try hip spica?
Sorry, I'm unable to hear you. Can you just type it? So when the child came to me, I did a net search and I found that congenital pseudoarthrosis of femur except in PFFD is not reported till date. Ajmal, I think when one operative treatment is failed and when we feel that the fracture looks like a pathological fracture, probably not a very wise idea to continue with hip spica, because it will lead to osteopenia as well as knee stiffness.
Okay.
Right. So I think MRI probably could have helped me, but I thought that this is probably an osteogenesis imperfecta. So what I did was I treated this child with dual rush rods. I freshened it, opened the canal, did a dual rush rodding, and then after a few weeks, I gave him alendronate, bisphosphonate injection, which is palmitate. Right.
Sir,
this is removal of the spica. Yes.
Sir, can I ask, sir?
Please.
Sir, usually in bisphosphonates also we have this level of fracture the same level, na, sir?
Yes, but that is after a prolonged use and generally in old age, not in children.
Okay, sir. Sir, and in the freshening, you told me, sir, you in pediatric case group also you will do shingling or decortication, sir.
Yes, we can do that, and that can be used as a bone graft, right?
Okay, sir.
Everything which was here in the side, everything which was here, it's all bone, right? Body was to heal it, but there was no stability and it did not heal. That is why you can all nimble that and remove the soft tissue from it and put it back there and there, because it's a healthy callus. It has BMP there.
Sir, and if this is the first day fracture, you will do the same or you will pass only one rush rod from the GT, sir?
In his case, when I digged into, I found that he had another 2 fractures, which parents had gone and treated with bone setters. So I deduced that probably they were small fractures which were not, they did not investigate. So there was no telltale sign of that on the x-rays. So, but the senior orthopedic surgeon did think in a proper line that this was a pathological fracture, though the diagnosis which was put forward was not a correct one.
Sir, what will you do if you are the first surgeon, sir?
Sorry?
What will you do if you are the first surgeon?
No, I would have done the same thing. The only thing is now the genetic testing is available. I would add a genetic test there.
Okay, sir.
Right. So this child, over the years, after a few shots of palmitronic acid, he didn't have any fracture on the right side, but he had fracture on the not on the left side. He had a fracture on the right side, for which I had done bilateral rush rod. Then he fell again on the left side. He did not have much issue. I was not there in the town. Sandeep, me and Taral were giving lectures somewhere. He went to another orthopedic surgeon who operated him 3 times, and unfortunately the child has come back to me. He has a delayed union of fracture shaft femur with probably some infection with a FD nail in situ. So this is old times, and this is the clinical result. Okay. So I think you should be very careful before getting with your, whenever you have a suspicious looking X-ray, it is a good idea to investigate, take help of a pediatric geneticist if you feel it's a disorder which you cannot diagnose, or dysplasia experts, or you can put it in your group, take advice of senior, and then only proceed for certain things. And percutaneous nailing, that internal decoration as rightly put forward by Sandeep, is absolutely a useless thing, and this will not give you anything but shame and complications, and you will lose even adult patients. Sandeep, are you ready to go ahead? And I'll switch on to your presentation.
Can you hear me?
Yes, sir.
Yes. So let me stop sharing and share your presentation. Give me a second. Do you see presentation, Sandeep? Okay, no, I think I'll have to. Okay, Sandeep.
Can you hear me?
Yes, sir.
Yeah, little bit lag is there, but
yeah. Thoda sa I am on the beach in somewhere near Kumta, that is North Karnataka. So you might hear the sea behind me.
You're much better. Yeah, go ahead.
Yeah, just bear with me. So this was a 6-year-old boy with fracture shaft of the femur. Can you show the next slide? I want the panelists and all the fellows to answer. How will you treat this? Elastic nailing, spica, plate fixation, or any of the above can be done.
We have one answer. A.
You can enter in the chat box.
Yes, we have one answer. A.
Everybody Ram wants to do tens.
Yeah, everybody wants to do tens. Yes.
Tens.
Yes.
Most of you want to do tens. Okay, fine. So let's go ahead. 6-year-old child, and like I said earlier, somebody did this.
Integration.
Okay, so probably they must have half-heartedly heard one of the lectures, and they put in nail, and they thought this is good enough, and then they gave a plaster that is an above elbow, above knee slab. Is that okay?
No, sir.
So after 3 weeks, just go ahead, Premal. Next slide. Yeah. So you can see in some time what started happening is that there is a varus collapse. So the principles of elastic nailing have not been followed correctly. There is a single nail put from proximal to distal, and there is no balancing force, and there is no adequate immobilization. Go ahead, Premal.
Yeah. Even the entry is pretty from the shaft, Sandeep, right?
Absolutely, absolutely. So then what happened was that the surgeon he has done, and this was an open reduction. So he thought that since he has the femur, it's a child, anything goes, anything heals. So he gave a long leg cast for 1.5 months. So that's the plaster. Then go ahead. But after removal of plaster, in 3 weeks, this is what happened. So can you analyze, Premal, what do you think is happening? What are the factors? What are the forces happening?
So I think here, as you said, that single nail is not able to counter the adductor force. And the adductors are
Yeah.
attacking the fragment, distal fragment, and trying to coalesce the fracture to get some union. And which nail is not able to, deformation is not able to prevent. So I think this is the health. I mean, because it's a healthy child, nature is doing all possible things to have the fracture in varus collapse and unite. So this is uniting fracture with deformity.
So what happens as you rightly said that if he had conserved, probably you would have at least got a united fracture. Now you have a situation of a non-union, a deformity, and a stiff knee, and a bad situation, right? And nailing gets
Yeah, surgery gets blamed because the principles are not followed properly.
has failed. It is the surgeon who has failed. Right.
Sandeep? Sandeep, it seems we are not able to hear you properly. So, since I know a little bit about this case, what was done was,
Hello?
yes, Sandeep, come back. Yes.
Yeah. So what happened? You see that he tried to remove the nail.
So he tried to remove the nail, but unfortunately, only one part could be removed, and the father was not very happy, and child was treated with spica. So
Hello, next slide.
yes, go ahead.
Yeah. So this is the situation he came to with. There was a bad deformity. There was some attempt at healing, but it was not sound healing. And then I had to next slide, please. Oh, yeah. So now what happened? Open osteoclasis. I could correct the deformity and I put a stabilizing plate and use local bone graft. But I did not. Hear me, Premal?
Yes, Sandeep, your voice comes, but it breaks. Yeah. So this is 3 months post
Can
of
you
that.
hear me?
Yes, but in between, there is
Yeah.
a.
So in three.
Sir, in the previous slide, there was a defect at the lower end of the femur, sir. Tried removing or he tried passing? Yes, sir.
Probably it's a rarefaction because of prolonged non-weight bearing.
Even on the lateral views.
Yeah, that's the same area, right? So sometimes
Yes,
growth arrest line comes just like that because of the previous trauma or surgery. That is only. I don't think there's anything there. This is a 3-month post-op, and this is 1 year after the revision surgery. Yes, Sandeep, can you come again?
Yeah, can you go?
Yes. Yes. So this child had an implant removal. Hiral.
Yeah. Hello.
Yes, sir.
Can you hear me?
Yes, sir.
Premal?
Yes, go ahead.
Yeah, the fun part. Sir was insisting why you didn't remove that nail. He was a mechanical engineer himself.
So what he's trying to say is that he removed the plate but didn't touch the intramedullary wire, and father was not very happy that that was not done because he was a mechanical engineer and were really concerned with the wire. But unfortunately, after a year, the child had a fall, and fortunately, it was through the same area where the nail was stabilizing it, and this time the child was treated only with plaster. And at that point of time, father was very happy that was kept. So this is a 2-year post-op and conservatively treated, and with a decent femoral bow, no limb-length discrepancy, and full fraction. So the learning points here are: inadequate stabilization causes non-union. Secondary angulation can happen due to Thomas's splint. And hasty dissections taken in panic can lead to significant trouble. Sandeep, you want to come again? Are you there? We can't.
Hello?
Hear you. Yes, go ahead.
Yeah. So this was a bilateral femur again.
Sandeep can't hear you.
You just take.
Okay, so what are the options here? Write your options. Okay. It's an adolescent fracture. 13-year-old adolescent. And roughly they are at the middle third in the middle third, lower third junction. So what will you do?
The weight of the patient, if the weight of the patient is okay.
It's very difficult to weigh
Yes, sir.
bilaterally fractured femur patient.
Yes.
No, it's not pathological. It's a road traffic accident. No.
No, sir, it's not. Nail both the fractures.
Which nail?
10 nails.
10 nail, 13 years is slightly on the higher side.
That's a weight. Lateral interfemur nail weight.
Under nail is an option, or as I have shown, you can use some other nail, off-label use, I would say. Right. So this child was managed like this. I don't know what happened. The surgeon ran out of ender nail or ran out of plate. I don't know. But unfortunately, one side was plated and one side was nailed.
Diameter of the nail is not as satisfactory, sir.
Yes, absolutely. But if you look at this, at 3 months, at least there is some union on the nail side. But the plate side, if you can see, is not doing well.
Premal sir, I had a doubt. Can we
the nails also backed out?
We could have used your idea of using a tibia nail in this.
That's what I'm saying, that
Yes,
as an use, you do that, definitely do that. But I think if you use decent size nails with a decent configuration, or I would even, you can put ender nail from trochanter.
Yes, sir.
all the way down just above the femoral physis. That also will give you good stability.
Okay, sir.
And probably you need to just splint them for a while so that things don't happen like this. But at least fortunately nails have backed out and there is some attempted union on right side, but left side there's a complete implant failure.
Yes, sir.
So now what? The situation, generally we inherit cases at this stage or even little later. So now what to do?
Intramedullary nailing.
I'll be going ahead, removing the implant and using the tibia nail, sir.
Okay, I think that's a fair option. Another option would be to use a longer plate. But here, the plate was removed, an external fixator was used, and Sandeep has used the same technique, shingling, clearing, opening the medullary canal, removing and using that same local bone graft.
Okay.
And you can see even nails not done in an ideal way. They're backed out at the lesser trochanter. The spindle is not there. If you see, the nails are crossing at two levels. One here.
Yes, sir.
Here. So this is called snaking.
Yes,
Or screwing, but at least they are uniting. At least they are uniting with a delayed union, but they are definitely uniting. Sandeep, you are not hurt, but everyone else is hurt.
Acha, so this girl, we restored the length with LRS and local shingling, and I made her walk early and removed that elastic nail which was bothering her knee.
Great. So this is the final results. She has full function and excellent union on both the sides. Right?
Sir, hello.
Yes. Please go ahead.
Sir, in this video, it seems that LR side it seems to be stiffness, sir. After the LR CPM or the movement will come on the routinely the movement will come back, sir.
See, what you can do is when there's a stiff knee, when you have a good fixation, you can bend that knee up to 90 degrees gently during the operation. And what I tend to do is then I use a lot of pillows and keep that in 90-degree flexion for a while. And from next day, you start mobilization. You can use CPM. CPM is a good option if you can get hold of it. We want to discharge the patient, and sometimes patients come from rural background where unfortunately we don't have access to this. And therefore, sometimes these techniques of high seating and local help of local physiotherapist is generally useful.
I'll ask them to use swing with the foot on the ground, sir.
Yes, I think right side was uniting well, and with external fixator, even weight bearing can be done on that side also. So that is one of the.
What I regularly use if I feel there is stiffness, I'll ask the patient to keep the foot on the ground and let them swing the swing, sir.
Yeah, that's a good option. But high seating exercises generally help well, and even during femoral lengthening, when we pass distal femoral shunt screw, we tend to keep the knee in at least about 70-degree flexion. So when quadriceps is impaled, it is already in 70-degree flexion. So immediate post-op, when you immobilize them in 90-degree flexion with pillows, and from next day you start mobilization. That is why I generally have very good follow-up movements in kids. Even if after lengthening they get slightly stiff, they get back the movement.
Okay, sir.
So this 12-year male had a fracture shaft femur and was treated with open nailing, ender nailing. So your comments on this?
So
bone contact.
Bone contact, the cortical contact is not there circumferentially. That is
yes,
one.
distraction is there. Absolutely agree. What else is there?
And sir, the ends of the ender's nail, one should be at least going into the trochanter, which is not going.
See, if you let it go in trochanter, it will give you good feeling. But here, what has happened? This is going very close to the neck. If it had gone, then probably some compression would have come. But since it is abetting the cortex here, it is not allowing this to collapse.
Yes.
So there is an advantage to that and disadvantage to this as well. But if you're doing an open nailing, you need to have good compression at the fracture site. That is for sure. At least good alignment should be there. Otherwise, there is no fun doing open nailing. But I'm sure if you are going ahead with a poor planning or poor operation theater backup, these things could happen. Right? So this is how everything was done. And 3 months down the line, one of the nail has broken. This has come out of the cortex and there is atrophic non-union. Generally, you get a hypertrophic non-union, but subtrochanteric area is one such area where the callus does not form very well. Right? So now what? Tell me, what will you do now?
Sir, I'll first remove the broken implant. I'll remove these implants. I'll do
How will you remove that broken nail?
piecemeal technique, sir.
Meaning?
Sir, what can be done is we'll have to go ahead and open the fracture site, sir. We will have
Yes,
to
so unfortunately, we'll have to again open the fracture.
site. Yes, sir.
Right? So at this point of time, if this child comes to me again, what I will do is I'll keep that broken nail inside, remove one of the nails and put a plate over it and graft it. At that point of time, I did not do that and I do something silly and then I repented for it.
Okay, sir.
Okay, so let us see what was done. This is how the situation was, significant osteopenia. So as you said, I opened it and I did a good alignment, bone grafting. I used the same local bone graft and put a nice locking plate.
Okay.
And locking plate had just come. I am talking about 2012-13.
Sir, could we have used LRS, a fixator, an external fixator?
To be honest, I am not very comfortable with LRS for non-union cases and that also atrophic type.
Okay,
See,
sir.
unions are also different types.
Yes, sir.
Right? So if LRS, my personal indication for LRS is when there is a deformity correction along with non-union, you want to compress it post-op or you want to lengthen it.
Okay, sir.
But every surgeon has his or her choice. And if they are happy with that, there is nothing wrong in using it. So what do you think will happen here? Will it unite or not unite? I have operated.
Sir, it should unite.
Oh, no, it's not like that. That is why this case is.
Okay, sir.
So what happened was in follow-up, he came back with Genuvaram and recovered.
Yes,
Sir, it seems to be healed fracture, sir.
Yes, sir. And there is one more fracture which
APU.
has been seen in the distal femur, sir.
Yeah, that is what. So where that fracture came from? He had no fall.
Enders nail entries.
Yes, so the enders nail were so much inside that I had to put a window to remove them. And I did not think that that window was very shallow and the forces will adduct the distal fragment. So this adductor magnus has pulled the distal fragment and quadriceps has pulled the distal fragment in extension and adductor magnus has pulled it in varus. So now we have got double situation, this locking plate fixation and this is the situation, right? This is the area where the nails were absolutely inside. This nail was inside absolutely, you can see. And while removing this, I broke this inadvertently. Okay. So this is after 11 months of this. So now what to do?
Sir, age of the patient now, sir?
Age of the patient 14. Now, see rather than asking the age, always look at triradiate cartilage. This triradiate is, so it is more than 12 years, right? This is how you tend to see these exercises.
Sir, I would not like to touch the proximal part because it's showing fair amount of callus there, so that is okay. Only thing of concern for us will be the deformity at the distal femur side, uh, which I feel, sir, we can go ahead and do an Elizaro.
So instead of doing what we decided was that we'll remove the we'll remove the plate, put a nail, and we'll do minimal invasive deformity correction as I showed last time, and we'll stabilize both the fractures. But unfortunately, in the hospital where I was doing it, IITV malfunctioned. It didn't work. Only child was anesthetized. So unfortunately, in that situation, I took a wrong decision of doing removal of implant. After that, he had some exams and said that we'll do the deformity correction later on. And he resumed walking and unfortunately had a twisted injury and broke from the screw hole. Unfortunately, that x-rays are not with me. So at this point of time, I used a conventional femoral nail, nailed it, corrected deformity with minimal invasive technique and interlocked that. And everything went off well. Both of them united, and he had a good clinical result at the end of 1 year. And at this point of time, he was already 15, so we have crossed the IFICS because he was riser 2 already at this point. But you can see the TBI is already fused here.
Yes.
Sir, we don't use bridge plating method in pediatric femur fractures. Sir. Bridge plating like with
I am a nail enthusiast, so if I can get away with nail, I'll always do a nail.
I'm talking about the earlier. First, you have managed with locking plate, na, sir.
That is what this was done in 2012, and at that point of time, locking plate came as a very promising implant. Then I burned my fingers. I rarely use locking plate in children.
Okay, sir. Now, will you use bridge mode, sir?
I would rather use a strong nailing and maybe add extra fixator to that. As I said, if that child would come to me today, I would not remove all the implants. I will remove one nail. I will retain one nail. I will not attempt to remove the broken nail, and I'll use a plate over that with bone graft. And then in one sitting, I will remove only the plate about 9 months and retain the nail for another 6 to 8 months, and then remove the all implants. That would be my today's thinking, which it has changed over a period of time with experience and burning my fingers, right? Not fingers, my hand sometimes. Okay. Any question?
No, sir.
Okay, let's go on to the third situation. 5-year female fell and developed swelling and fever. It was in October 2010. So what will you do? She has high fever, inability to stand and move. This is her X-ray.
Swelling it, sir?
Left thigh. Can you not see the swelling here? See the side. 5-year female thigh. Both views. Even subcutaneous tissue, you can see here there's a swelling, right? Subcutaneous tissue, cellulitis like changes are there. See, if you look at the X-ray, a lot of things you can see actually.
Yes, sir. First of all, in the X-ray, in the proximal femoral side, on the lateral view, maybe it would be an artifact or something, but there is a breach in that cortex. Yeah. Yes, sir. Yes, sir.
That is GT.
That's a greater trochanter physis.
Okay. Yeah.
Yes, absolutely. That's not a fracture, right? That's greater trochanteric physis. When it comes end on, it looks like that.
Okay, sir. So we can go ahead and do a blood workup. We can get his CBC, ESR, CRP, and blood culture testing done.
So I think CBC and CRP was done. They were highly elevated, and the child was treated with IV antibiotics.
Okay, sir.
So do you agree with that treatment, or you want to differ? So what will you do?
Infected hematoma, sir.
How do you know there is infected hematoma?
Swelling, local temperature, sir.
No, but where is it then, and what will you do for that?
Sir, infected hematoma, my only concern is that happens whenever there is something known as a mural level lesion, which we see in adult population. But if the
This
skin,
is a child. What will you do? Any investigation you are allowed to do.
yes, sir, CBC,
Your
ESR,
child, any child with normal X-ray, significant swelling, raised CRP,
Alright.
high-grade fever, what will you do?
I'll go with MRI for this patient, sir.
Yes, you should go with MRI and do the needful. Unfortunately, surgeon or a treating pediatrician or probably general surgeon who was there never followed anything. So what do you expect here?
Only diagnosis osteomyelitis for now.
So with this X-ray, what will happen next?
Pathological fracture, sir.
Sequestration, pathological fracture. Unfortunately, the still guy kept on waiting. This is 6 months down the line. This child came to me with a posterior draining sinus which grew pseudomonas, and we had to give that some very rare compound which comes in granular forms, which generally is used by after prostate surgeries or very recalcitrant urinary tract infection. So this was 2019 May. There was a posterior sinus very close to neurovascular bundle, and significant shortening, significant osteopenia, and stiffening. And already one surgery was done for drainage. After everything, bad things happen. Right? This is rather a long thing, so I will go ahead because at this point of time we need to do something. This was during my assessment in the operation theater. There was a frank community there. What I did was sequestrectomy was done, and what I did was vancomycin impregnated cement spacer was put. So what generally I do is I take a 20 cc syringe, cut it at both the ends, and make it a hollow. Then cut it in the center. Then I put it one on the opposite side of the bone. Then put lot of cement with IM nail in situ, and then I will put another half of 20 cc syringe. That generally matches the diameter of femoral shaft in child and gives you nice round thing, and it becomes very easy to remove later on. So you can see the intramedullary nail is passed. This is the cement spacer, and the same cement spacer you can see here. And I generally use an Eschmark bandage. Even in femur higher you can use, so you can get a beautiful bloodless film. Yes, Ram?
Sir, the vancomycin that you have used in the mixing like 2 grams for 40 grams of PMMA and 6.5
20 grams.
ml.
I generally use 20 grams. In children, 20 grams is more than enough.
So 1 gram, 1 gram of vancomycin.
Yeah, 1 gram of vancomycin in 20 milligram of
20
cc cement. Yeah.
Okay, sir.
So sinus was healed. So in second surgery, I removed the spacer, did a fibula graft, and did an Ilizaro. This is a special technique of mini incision fibula harvesting. So what generally we do, Taral has taught me this technique. What we generally do is we put a small incision up and down at the required centimeter. Suppose if I want 8 centimeters, this incision 8 centimeters, you go all the way to fibula, then subperiosteally go all around the fibula and slide your periosteum from one end to another end, this end to this end, all around. And then you do the drill holes and cut the fibula. Then what you do is you hold the fibula like that and bring it out. So this keeps the periosteum absolutely intact, very small incision, and it grows the fibula back very well.
Sir,
yes.
Sir, at the middle one third of the fibula will have artery, sir. What we regularly use for vascular fibula graft. Have you encountered any?
Yes, but that enters through the because we are going to take fibula anyway with that.
Yes.
So, but if you are extraperiosteal in the artery mode, nothing much will happen to that artery.
Okay, sir.
Right. So this is the X-ray immediate post-op. This is a few months down the line. She started having issues with the pins. She was comfortable initially, and she was mobilizing well with the foot drop stuff and everything, and walking full weight bearing. But then the dressings were not available, and child was really tired with Ilizaro. So we converted. We removed the implant and put the child in a walking spica. See, Taral has mentioned about walking spica. This is the example of walking spica. Right? You can see the child walking actually with a spica. You give a short cast and keep the foot free, and the child will be able to walk full weight back. Right? So after this few months, I was not very satisfied with the union, and there was a stiff knee also. Right? The joint space, if you see here, is not very good. So now what to be done? Tell me. Now there is no infection, but the union also is not very good. So what will you do now?
Sir, what about the quadriceps?
Now the knee is stiff. So what knee is all
Like if the quadriceps is contracted, we
the quadriceps is contracting. You can look at here. You can see
yes, sir.
quadriceps is contracting.
We Vivoplasty of the quadriceps.
No, the joint space itself is going. I think the infection was in the joint also.
Yes, sir.
Case is not there. I would not bother to do quadriceps plasty if I don't have a good union of the femur. I think union, without bony union, you can never achieve a good range of movement in the any knee. So first thing is our union. Any takers?
Sir, can we? Is the patient willing for a Ilizarov again?
Even patient is not willing, nor I am willing.
Then LRS, sir.
LRS is hardly any hold in LRS.
As there is no, as the knee joint is gone. What about
but there is a hope of knee joint still. Maybe you can do arthroscopic adhesionolysis later on or something with VY plasty. That option we don't want to burn.
Okay, sir. Plating with bone grafting, sir, for femur.
Yes, good idea. Good idea. We did that. Plating, iliac crest, bone grafting. This is 2 and 4 months. This is on removal of spica, and this is 4 months later. Are you happy?
No, sir.
Sir, anteroposterior view is not clear in this X-ray. Okay, sir. Okay, sir.
This is AP view. This is AP view, and this is.
It's okay, sir. It's okay, sir.
See the knee joint is going.
Correct lateral. Sir, there is a atrophic non-union. I think so, sir.
We have done nailing. The nail is also inside. As you know, I told you that I would like to keep the nail inside. We have changed the nail also.
The nail seems to be posterior, sir.
Yeah, but it is there inside the bone, right?
Okay, sir.
Yeah. So, what do you expect? What will happen?
Sir, I think that there will be a deformity again at the fracture site, and the plate will break at the fracture site. That is what I feel.
So she continued having. You can see the quadriceps. You will be able to see somewhat quadriceps. You can see the quadriceps is there. You can see she's able to activate quadriceps, but unfortunately the knee has no movement. What happened? This is how she's walking. And this is how she came to me. Okay, after a few months. So now what? Now the knee is stiff. The plate is not working. This was a simple screw which is backing out. This was locking screw which is coming out with this thing. So now what?
Sir, your experience with accordion maneuver, sir.
Accordion maneuver is good with length, not with non-unions. And that also infected where, there's infected non-union surrounding muscles are also not very normal.
Okay, sir.
So,
sir, if it is okay, we can fuse the knee joint, put a Cyrus nail, and do a Elizaro over it.
Cyrus nail in a 6-year-old girl?
So,
will it go?
I mean to say a long femur tibia nail.
That's very difficult to negotiate. It will cost your...
Yes, sir.
It was a humerus interlock at the most.
And knee seems to be fused here, sir.
Knee is not there any longer.
Yes, sir.
Yes, sir.
Technically or radiologically.
I feel a Elizaro for the femur deformity and non-union. I feel that would be a good enough option for this patient, sir.
And patella as a graft, I know how knee joint is fused.
So patient was not very keen on Elizaro again because they had issues with remote area with dressings and other thing. So they requested me that can we do something else, and somehow I felt that the plating would work. So I did a repeat grafting. I shortened the bone, put a iliac crest bone graft and used slightly thicker plates and went all the way from trochanter to distal femoral physis, all the way there. Changed the name again, gave spica for about 2 months, and this is the 2 and 4 month follow-up. This is 9 months follow-up, and this is now she's currently 1 month back. So, see, infected non-unions can really be recalcitrant, and you really need nerve and good patient to work with. I'm very thankful to this patient who had so much faith in me that I only did about 3 or 4 surgeries in this kid, and still they are following up with me. That's a great thing on part of parents to have faith in a doctor with multiple surgical failures. Right? So sometimes there are very humbling experiences in the practice, and infected non-unions are one of the worst things to treat. Yes, Sheetal, your comments on this?
Sir, what is the shoe rise size, sir, approximately?
Sorry?
Shoe rise, size of the shoe rise.
She has now 3 issues. The knee is fused, distal femur growth plate is fused, and proximal tibia growth plate is fused. So we are expecting limb length discrepancy in tune of about 12 to 15 centimeters. And shoe raise at this point of time is about 6 centimeters.
How was it like epiphysiodesis?
No, I have not done epiphysiodesis. This all happened because of the infection.
For the opposite leg, sir. That may prevent future few rise, no, sir.
But then she'll be very short, right? At 7-8 years, you can't do. She's now 8.5 years. You can't do epiphysiodesis at 8.5. She'll be very, very short, and with an absolutely abnormal torso to lower limb ratio. Sheetal, how would you approach this child with a second failure? Were you during the case?
Yeah. Can you hear me?
Yeah, very well.
Yes, sir.
So, these are really tough cases. As you pointed out, there are no, ideal or right answers. A lot of times you try the fixation methods. One thing that you always have to suspect with a non-union in a child is infection. Even though it may not, like this was infection for sure, but sometimes, if you have delayed union, non-union with open fractures, or if you have opened a fracture for fixation, you have to be concerned about infection. It could be just a very low virulent infection, but you still have to be concerned about it because kids don't need too much stability. So in adults, when you have non-unions, you're concerned that, it is, hypertrophic non-union, and it could be because of a mechanical issue. But in kids, you don't need too much of stability. You can fix a lot of things with K-wires and, biologic types of fixation. So whenever there is delayed union, you have to think more about biology than mechanical issues. So, what would I have done? Probably, similar things. But, if someone says that I would have put an IFICS, someone says I would have put an nail in, there is no right or wrong answer. The thing is that you need to make the patient aware of a few things. One is that when you have an infected non-union, he's going to need two-stage surgery. One is to clean the infection, second is to treat the fracture. So that is something that you have to let the patient know upfront. The second thing with this patient having infected physis and the joint, again, at this stage, the bone is healed, which is great. But, when you have a discrepancy of this much, length in a young child, you again have to tell them that this would be another 2 surgeries for sure, at least 2 surgeries. So one is you might have to undergo lengthening twice, might not want to lengthen so much in one setting. So you may do a lengthening now. And then maybe when she is, around 12 or something, you can do an epiphysiodesis of the other side and lengthen her one final time. So she would need 2 surgeries for management of limb length. And she would, when she had presented, you could have told her 2 surgeries, at least 2 surgeries to manage the infected non-union. So if you tell the family upfront that these are the procedures she is going to need, it's not, a straight or a simple case, then you don't have to explain a whole lot later on. If you tell the family upfront what you expect, then it doesn't seem like you'll be making excuses later down the treatment, because you know that this is how the patient is going to present and how much surgeries they would need. So the patient sticking with you for this long of a time, that means that one is that you did explain them very well. They have faith in you, and that you have to be upfront in the sense that there is no one who can treat this in 1 or 2 surgeries or get an ideal result. Everyone, whosoever is treating it, is going to get more complications down the road. So it's better to just be honest with the family and let them know everything up front. Of course, the best thing that could have been done is to prevent this from happening. So that is where the awareness comes in. This case, when they presented, if an IND was done, this could all have been prevented. But and
that is probably the most important message of this case. That I think if you act in time, all these stupid things, then I think we are looking at about 7-8 surgeries in the child. Everything could have been prevented with 1 surgery in time.
Right, and even after doing all this surgery, she's still going to have a stiff knee, a weak leg, a limp, and everything. There is, so if the first treatment would have been done on time, then all of these things could be prevented. Now, even in even here we have seen that. So even in a developed, society where everyone has access to everything and everyone is aware of things, it happens if the patient has other comorbidities or they're getting treatment for something else, like if they have some form of malignancy and been treated for that, and then they develop this, then infections do go miss because you're more focused towards your other treatment options or other treatment. And we have seen trauma patients who present and later on get diagnosed with a tumor. And we have seen patients who present with fractures who later on get diagnosed with infection. So whenever you have these trauma, infection, and tumors, you always have to suspect it if things don't go in the manner that you expect. So if you have a trauma that is not healing on time, then of course you should expect 2 things, infection and tumors. And same thing with all the other things. So, my teaching point is that always, when you have a tumor, you always culture a tumor. And when you have infection, you always do a biopsy. Okay? So make sure that you don't take it for granted, because they can be together. And they can both, tumors and infection can present with trauma. It just needs small amount of trauma. And you may think it's a fracture, but it's the pathologic fracture, or it's the I would just make sure that these things don't happen. Like, I don't know what you could do to prevent this, because the initial treating physician or whosoever treated, it may be a bone setter, whosoever did it, I think the education is the key. And I don't know how we can educate the others. I mean, we all orthopedic surgeons, we know that this is urgent, but I don't know if someone else, like a primary care physician or a bone setter, is taking care of it. I don't know what we can do to educate them, but probably something needs to be done to see if these things don't continue to happen.
I agree. You know, the other day I posted in a posse group that in a teaching institute in Ahmedabad, one of the largest hospital of Gujarat, a child with a septic hip was operated from trochanteric incision. I don't think they could ever enter the hip joint. Ultimately, the femoral head is gone. So I think these basic surgeries at a teaching hospital, if consultants cannot perform, even consultants, I'm not talking about residents, then probably I think the system is not, the right system is not in place. And what I'm seeing is most of the consultants are not very keen on operating pediatric sepsis somehow. They want to manage with antibiotics. And unfortunately, 25 years down the practice, Sheetal, this type of cases are still plenty, unfortunate. You are right that something needs to be done with teaching, but unfortunately, nobody wants to, I mean, everybody wants to learn fancy implants and fancy surgery. If you're out of SSD, you will have 150 registration, and if you talk about pediatric infection, there will be hardly 15 there. Anyway,
Yes, sir.
that's the irony of the situation, but let's go. You're going to be around, Sheetal, now for a while? 15, 20
For another 30 minutes, yes.
Okay, so we'll wrap this up in those things. Okay, so as Sheetal said, another patient, open tibial fracture managed elsewhere, had burns and fell in a burning house, and then he was treated primarily by a plastic flap and plastic procedure, and primary JES was done. Unfortunately, there were no old records, and child came with this. Right? Any options of treatment you would like to suggest here?
So, present inflammatory markers, sir?
Absolutely normal. Everything is normal at this point of time now.
So, I would like to freshen the edges, and I'd like to keep bone graft between fibula and tibia, sir. Syndesmosis between the tibia and fibula. And I feel that there is a disruption of the lower face of the tibia was affected in anteroposterior view.
Probably, but you know, we can't be certain.
The syndesmosis was also affected, sir.
Possibly, yes. But since you're going to synostose both of them, it's not going to be mattering much. Right?
Okay.
Your take on this?
Are you asking me? Did you ask me something?
Yes, Sheetal.
Oh, sorry, I did. So I think there is, look like there are lucencies. I don't know if there is a question, but it's atrophic.
No, this is not lucency, but this is X-ray got a little damage because of the water. Originally.
Okay. Yeah. So there is still atrophic non-union. So it's a biology issue. One thing with these fractures, I would make sure that I have a plastic surgeon, with me, because I know if they already had a flap and skin, whether they had a skin grafting or not, I always, take help from a plastic surgeon, because once you open this and bone grafting and everything, then wound healing, infection, all those secondary problems, you want to make sure that, if needed, you can do a flap coverage or your plastic surgeon friend can do it. So I would recommend that if a plastic surgery has been done, or if you're, managing soft tissues, make sure that you involve them upfront and not try to handle too many things yourself. We are, as an orthopedic surgeon, we can be really good at fixing bones, but soft tissues, they would need equally important. So we are really fortunate. We have very good team here, but just make sure that you have at least one good plastic.
This was done at Shardhaven hospitals, and we had access to plastic surgeons, and they were involved, as you rightly very well said, because this was already treated earlier. So I think any wound which is probably
you can do it, as most of the non-unions, if you're suspecting infection, you do it two-stage. First, if you can clean up, take biopsy, take cultures, and stabilize it if needed with an IFICS, and then come back in, bone graft it once the biopsy is okay, or once you have treated the infection with antibiotics, then come back in and fix it definitively. You can use antibiotic, cement in during the first session if you think that it is infected. But you want to rule out infection, you want to optimize nutrition, make sure that the patient is overall healthy. So you have to look at the patient overall as well. I'm pretty sure a lot of these patients, especially in India, would be malnourished and would have other issues. You want to make sure that vitamin D, and make sure that they have a healthy, overall they're healthy enough to make this deal.
Yeah, to be honest, Sheetal, in 2009, we were not very informed about vitamin D levels. Now I think vitamin D is, we always precautionary give. But in 2009, I don't think we were very aggressive about vitamin D levels at that point of time. But of course, this child comes from a little lower socioeconomical thing, had a few surgeries before coming to me, but everything was quiet for last 3-4 months. And that is how we started. So this was the local condition. This is how some rotation flap was done, horizontal incision you can see here for the rotation, which was opened by a plastic surgeon. And we found that there was absolutely atrophic stuff, which we removed, did an acute shortening, did some, I think we used that end nails, which were available by Naveen Bhai at that point of time. And unfortunately, I couldn't negotiate beyond this. So this is 3 and 5 months post-op. It still collapsed further and came out slightly more. That's a 9-month period. It was not a very good situation. It was going for hypertrophic non-union, but the cross union was happening. So I was hopeful that things would be okay. The child was being mobilized with PTB and was doing okay. 19 months, I thought things are a little improving. And child had some issues with this prominent nail, so I removed it. This is 6 months post ROI. I wasn't very happy. I thought the child should continue with PTB, but unfortunately, he was not wearing it and fell again. So now we are back to square one, about 3 years down the line. So now what?
Sir, we have deformity. We have deformity and pain, no, sir. So
yes, there is deformity, but child is walking full weight bearing with some limp, because there's a synostosis which is well established between tibia and fibula now.
Yes, sir.
See here, right? Yeah.
So we'll go with Ilzarov fixator.
Shitar, your take.
So a few things. Initially, I would have managed it as a 2-stage. As I said, it doesn't matter even if it's confirmed that there is no infection. I always like to make sure that I take a biopsy, check the local area, and make sure there is no infection before I put any implants in. So I would have done that a little bit differently. Now, this is a well-known thing that I have had a similar patient with an open tibia fracture. That seemed like it was healing fine till he had a minor incident and it cracked just like this. And I think what I would, one thing is that when you have a deformity, it makes it more prone to, recurrent fractures or refractures. So when you're fixing it, you always want to make sure the alignment is right, stability is correct, and then you can fix it with implants. And, if the deformity is increasing, which happened over a period of time, that means that it's not completely healed, unless you think it's growing crooked, which normally doesn't happen. So it probably, was going in for delayed union and kept on increasing the deformity. So, at this time I would, I don't mind doing another, nail exchange nailing, or, do another set of nail. The only thing is with hypertrophic non-unions like this, it may be difficult to pass the nail because there is a lot of callus around that site. So you got to be prepared with some retrograde, drilling if you're planning it. The other obviously, you can do an external fixator, or you can even plate it, in this area, because you have to correct the deformity anyway. So you can open plate bone graft, and that I don't think that there is any right or wrong answer. As I'm also more fond of using for the diaphysis at least, more fond of using nails. So that's my preference. But I guess plate probably may be more stable here, because here it's a stability issue since it's hypertrophic.
I agree. I am the same. I sail in the same boat. Enjoy doing nailings more than, and more so the skin was tight. So I thought plate would be a best implant here. So what I did was this was the deformity as just to magnify that there's significant deformity which is probably not very obvious on oblique X-rays. So I did an acute shortening, bone grafting from the local area plus iliac crest grafting, double nailing. And deformity correction. This is 18 months post-op, solid union, and full function. Right. So as Sheetal mentioned, all three was a good option: plating, nailing, and external fixator. Maybe Elizarov could have done the same thing. But I always think intermedullary implant gives you good stability and lets you mobilize them much faster. Even if Elizarov is there, sometimes repeat fractures are there. With nailing, repeat fractures are definitely less. Sheetal, any comment?
No, I think I probably would have done the same thing. Did you have trouble passing the nails?
Yeah, it was all done open. It was all open, and I did excise about 1 centimeter of distal fragment and removed all the sclerosed bone because that was significant. Yes, Ram, you have some.
Sir, how much of the acute docking is permissible in pediatric age groups to prevent kicking of the?
I think if you can, I think about it. Maybe it is just safe to do 10% of the bone segment, right? So if you take the whole length of tibia, 10% you can shorten. So here there is no rule of 5 centimeter, because the child size will be different. So 10% of shortening and not more than 25 to 30% of lengthening. That is the dictum. More than 30% of lengthening also leads you in trouble. Sheetal, any different figure you would like to add? I think 10% shortening and 30% lengthening is generally my take.
Yeah, no, I would agree.
Okay, let's go to this second case. This 10-year female closed injury in August 17. How would you treat this? She's 10-year female, open physis. Yes, options.
How about do you think it's a closed injury? You can do a closed reduction and cast?
Absolutely. I think that is one of I think I would have done the same thing. But that is why I bring in these cases that everybody wants to fix in India. Nobody wants to plaster. I'm just trying to show what happens to nail it.
Yeah. No, I think it even here, because I think nailing and fixing makes it easier for patient care, for surgeons as well, because close reduction and casting is kind of a little bit more
painful. Yeah.
Yeah, you have to manage them, so you have to see them repeatedly for the first 2-3 weeks. Even though it's the right thing to do, things may be moving a little bit away from managing in the older age group, like 11 plus age group, trying to do more nails and fix them more rather than using casts, just because it takes longer to heal and it's high maintenance. So from a feasibility standpoint, a lot of patients and physicians are moving towards surgical treatment. But if you want to try close reduction just one time, and if it's a really good reduction, then you're fine. You want to make sure that since both are fractured, it's more likely to go in valgus. So you just want to give a good mold.
Yeah, so I think we will be able to definitely reduce better than this internal decoration. Would you agree, Sheetal, that if you don't can correct this deformity much easily with plaster?
Right. You could have wedged it if this was just a plaster, but this is something which you expect. The deformity going into valgus with both of them fractured around the same level. So you want to just give a mold. If you're doing nails, the same thing. The principles don't change. So you have to make sure that you don't leave a gap. You have enough length on your nails. You mold it properly. And here it just shows you that there is too much of gap and not a very stable fixation.
And once you bring this nail out, it doesn't let you collapse. So whenever I see perforation, I'll be very, very wary of union. I'll be very having close watch. And she presented to me after 20 months. This was her thing. And I think it was a day one failure, and she had good stability. So she kept on walking, but she did not have any union. This is after 28 months. And this is when she came to me. She had a limp and she had a valgus deformity. So what should we do now? Let first fellows answer, and Sheetal, then you give your comments on this. So this is 2.5-year-old non-union, probably atrophic type by now, with a valgus deformity. But child is not having much symptoms. What to do with 3 nails in situ?
The latest X-ray, sir. I mean, the last X-ray.
Yeah, I'll show you again. This is the X-ray. The fibula is united, and tibia is distracted and not united. With valgus.
I'll do fibular osteotomy and change the endosnail to tensnails.
But why not interlock it? You know, if you see the tibia is already fused.
Oh, yes, sir. We can go with interlock.
Yeah, so I think it's always in children. You should always look at the bone age rather than chronological age, right?
Okay.
Now we are tibia distally it is fused, and you always ask about menarche. She was already 10 at this point of that 10. Also, she was little heavy. And in Indian girls tend to get early menarche now. At 11.5, 12 is most of the girls can get menarche. Especially from the urban background. So interlocking nail would be a good choice. Sheetal, what would be your suggestion for this?
Yeah, even with the interlock nail, I think you might need the fibular osteotomy to have to impact the fracture site. Otherwise, it will stay distracted, and you want to correct. If you want
deformity
to
also. Yes.
If you want to use tense nail, that's fine. You can use it just osteotomy. Make sure that you correct the deformity and you do balance nailing. This was a closed fracture to begin with, and it was treated closed.
Yeah.
Can you hear me?
Yes, sir.
Yes.
Yeah, I'm saying this was a closed fracture to begin with, and it was treated closed. So, the suspicion for something else is, pretty low as far as infection is concerned. So I would, just consider this to be a mechanical failure, of the implant. So if you want to revise it, I would go with the interlock nail. But if someone, wants to, say for example, this patient was a year younger and had open physis, I would have then, gone with tense nailing, but correct the deformity, do fibular osteotomy, impact the fracture, and it should make it heal. I mean, this is, this is much simpler compared to other cases that we saw.
So I advise her exchange nailing. And she said that she was not very keen on major surgery. So she went locally back to a local orthopedic surgeon in a medical college, and who just treated this child with removal of implant and plaster. And parents were not very keen for surgery. And he said that we'll wait for a while. And after 3-4 months, we'll take the decision of second surgery. So implant removal and about 3 months of plastering was done. And he was kind enough to share this X-rays with me. The patient didn't come back to me, but the treating orthopedic surgeon was kind enough to share this X-ray with me. I was absolutely pleasantly surprised with this result.
Yeah, but still there is deformity. So
there is.
So it heals, that's fine. But with this deformity, whether it would lead to issues with the ankle joint later on down the road, the other thing is you see that there is significant, gap between the great toe and second toe. Probably she is syndromic, or I don't know, Down syndrome or something. She has some form of dysplasia. So you just want to be, careful. Healing is one thing, and it has healed, so that's great. I would wish that when he removed it, he would have tried to, correct it. It would have been difficult because it was like this.
Yeah, because fibula was solidly united, so any deformity.
The fibula would not heal. But so it's good that it's healed, but not ideal.
Yeah, absolutely agree. But this was a surprise to me. I thought it would never heal. To be honest.
Yeah. Right.
Yes, Ram, you want to say something?
Sir, question to Setu, sir. He told fibular osteotomy, that removal of the fibular oblique osteotomy and the level of osteotomy for if he wanted to do fibular osteotomy?
So I wouldn't do it at the same level as the fracture. Probably, you can do it a little bit lower or higher than the fracture. Higher, you have to be concerned about the nerve as well, so be careful about it. But I don't think that you need. I would do a oblique osteotomy, like a short oblique, but I don't think that it would matter where you do, as long as it's within the deformity of the fibula, because you got to correct it. So if once you cut it, fibula is not usually an issue. That means that, like here it's all healed, but the previous X-ray, since the tibia was not healed, once you do an osteotomy around the apex of the deformity for the fibula as well, you should be able to correct, both of them.
Okay.
Reasonable level would be here or here. Here would be.
Yeah, I would not do it at the same level because of the synostosis, the potential to have cross union. But within the deformity, it's fine. You can use it, and once you cut it, you'll be able to correct this deformity pretty easy. It's not going to be difficult.
So this also had come to me with this deformity and this hypertrophic non-union. He didn't have much history, and we investigated him for dysplasia and we couldn't find anything. He had a significant shortening and hypertrophic non-union. I think some bone setter treatment, but I really couldn't establish the diagnosis. And I couldn't explain even the shortening which he had. Right, Sheetal? How can you explain so?
Yeah, there is something going on. Even if you don't have a diagnosis, there is something going on.
So because here it was, I was not very sure. I didn't want to take chance, and there was a significant shortening. As I think you earlier fellows asked me, my indication for using LRS or Elizarov is when I want to either correct the deformity with lengthening or I want to compress it. So here, this is the preoperative amount of shortening. You can see good knee function, ankle function was reasonably okay, and this is how the child was walking. Right. So I won't go much into detail. What we did was acute shortening or acute deformity correction, IM nailing, and proximal corticotomy. This is during the lengthening. This is the end of the lengthening, and this is how after final consolidation was there. And that was the clinical result at the end. I think still the child is short by about 3 or centimeter, but they don't want any further surgery. They're coming from somewhere close to UP and cannot come back. So I think they stayed there in Ahmedabad for about a year or so, and that is the final result I had at the end of the year. Should your comments on this? I accept one submission that I don't have diagnosis for this child.
Sir, can't it
be? I think that looks good.
Yes, Ram, you wanted to say something?
Can't it be congenital pseudoarthrosis, sir?
He didn't have clinical signs, though, of NF or anything else. And he was very categorical that there was some trauma and for which it was a bone setter treatment. And one thing about CPT is that it will never be hypertrophic non-union. Right, Sheetal?
Yes, sir. Yes, sir.
Yeah. I mean, if you look at the classification, it's the last stage is atrophic or,
yes.
Atrophic non-union. So it's unusual. And then, you have other clinical signs that you can just look at the patient for the capsular spots and, freckling in the axilla. So you can, a lot of times you can make clinical diagnosis as well in NF. So this patient probably didn't have it. They at least didn't look at it on the x-rays. Didn't seem like it.
And there was a proximal tibial physis also gone. So it was a freak injury, maybe something was missed, or I don't know.
Yeah, I saw that the proximal tibial physis was stented. It looked like it was. That's why I thought that it may be a dysplasia, because if you go back and look at the proximal tibial physis, it was stenting as if there is a central growth arrest, or on the very first X-ray, you see the proximal tibial physis, how it's tenting there.
Yeah, absolutely.
So that's not normal physis,
and even the fibula is not overriding, right? That's so many odd here. So
yeah,
the diameter of the femur.
Femur is absolutely
diameter of the femur.
No, I think it is the view like that. because I think some should have at least given before X-ray should have given compensation, which was not given. So the rotations and everything is not correct, and the child is standing in such a way that one femur is away from the plate than the other. Anyway, so this is one of the options of treating I wanted to cover. And going to the last case, this 9-year female, road traffic accident with a skin abrasion. How would you proceed for treatment? The abrasion is right over the medial malleolus.
What is the classification, Salter-Hayes classification of this?
Yes, so how would you classify this? You can write it in your chat box. No answer, Sheetal. Tough question.
Yes, sir.
So, there is a classification specifically for this. If you're missing physis, a missing part of the bone, you need to look it up and let us know. So that's your homework. A lot of the fractures you cannot classify by Salter-Hayes. So say, for example, if you're not missing the physis, in this case, probably you are. But if, say, for example, you had this fracture here, which is not extending to the physis, it's purely epiphyseal.
Yeah, this is an epiphyseal injury than physeal. Yes, absolutely.
Then you cannot classify it by Salter-Hayes classification. But still, there is one. You can apply the missing physis classification here if it's an open injury and it's scraped the physis there, because then you know what to expect. So you need to know the alternate classification system, which are out there, and there are some extensions to the Salter-Hayes type, classifications as well. Rang classification is the one that is used, and if you have a metaphyseal fracture with an extension towards the physis, then there is no Salter-Hayes classification for that, but there is a Peterson classification. So the reason that it's important is because once you classify it, or once then you can look at the prognosis, or you can predict what is going to happen based on the classification. So not just from for the sake of classifying it, but from research and from treatment perspective, it would help.
So Sheetal, what would you do? This skin abrasion 9-year, no takers for this. I think it's a long session already. So
yeah. So well, I would get if there is skin loss, the tissue loss, I would just make sure that we have someone who can help me with the coverage. But I would.
So there's an abrasion, no skin loss.
Okay, so then I would just this medial malleolus fracture is below the level of the axilla or the shoulder. I would just make sure that I look at the X-rays properly, a third view, or maybe even a CT. There is a Salter one on the other side. It seems like based on the tissue swelling there. So I would if I had to fix it, I would just put maybe 1 or 2 K wires in the medial malleolus, or maybe a small cannulated screw, but stop short of the physis. And then if there is more instability at the fracture once I fix it, then maybe a K wire in the fibula. So that is what I would. That is my initial plan. Now you have to make sure that once you're in surgery, you check with the fluoro, make sure there are no fracture lines which are not apparent on the X-rays, and you may have to change a plan a little bit intra-op. But this is overall going in. This is what you want to think about is your tissues, like your soft tissue, whether it needs coverage or how you can prevent it from getting in the way of your healing. And second is your backup choices, your K wires, cannulated screws. Probably those would be enough for this case.
So the abrasion, this orthopedic surgeon thought of treating it conservatively. So 1 month plaster was given, and this is the situation at 1 month.
So, the issue with conservative treatment, probably you can make a case of treating it conservative on the fracture, but, if this is going into the weight-bearing area here, if the fracture is a little bit lower, I would probably agree more with, with treating it conservative. But the fracture line going, towards the weight-bearing or right where the axilla is, then you have to kind of be a little bit more concerned that it might not heal or might displace.
This is 2 months down the line. And this is at the time of presentation. Now the abrasion is there. This was the abrasion, which, sorry, This was the abrasion which healed well, and now you can see she has a significant limb and not able to weight. And
so so here you have to decide whether, if you excise this piece, whether it's going to be unstable or not. Because if it was a little bit lower down, you can consider excision of the malleolus. But here it seems like it would affect the stability of the joint. It might be a better idea to fix it. And so when I was talking about the missing physis, I thought that there was an open wound there. I didn't think it was an abrasion. With the abrasion, I would not be too much concerned about missing physis, but there is a specific classification. What I was talking about is the medial malleolus specifically has a classification where you lose the skin and the physis gets scraped, and you have a high rate of physeal arrest. So you have to be careful about an open wound on the malleolus when you have a fracture, and you can. So that is what I was talking about.
So this was managed by with compression K-wires, and I used K-wires and took some bone from tibia and just put it there. Did an arthrogram to confirm that I had a good articular cartilage, and just 3 K-wires. Of course, they were slightly long, but then I was not very keen on changing them. This is a serial follow-up. This is her movements. This is her follow-up gait, and that is 3 years. That is 3 years down the line. Sandeep in one of the meetings said that if you leave the K-wires in for long period, it can lead to growth arrest. Unfortunately, this girl did not, because in between she was lost to follow-up, and she came back only after 3 years for removal of the implants. And she really did well. I don't know whether I was lucky or prolonged K-wiring causes growth arrest. I don't know if that theory is correct or not.
Is the fracture healed, or is it like a non-union, which is asymptomatic, you think?
I don't know. She has no tenderness at this point of time. And her gait.
Yeah, so, I've seen that even if you leave, that was what I was saying, that, even if you leave this fracture, if it's a little bit lower down and it goes for a non-union, it's not that big of an issue here. I've seen that, and we all feel compelled to treat it when we see a non-union or when we see a fracture like this. But I don't think that by treating this patient non-operative, I would have treated with surgery, but I'm just saying treating it non-operative, I don't think I can say that it is really a bad decision. But if it was, say, for example, a Salter 3 or a Salter 4 of the medial malleolus, then I would say it's a wrong decision, because then you want to fix it for sure, because the growth arrest rates are like 40-50%. If you have the medial malleolus fracture going into the physis, you got to fix it. You don't want to treat it, non-operatively. And the other thing is that the K-wire, when it goes to the hump here on the medial side, that's the Poland's hump, and that is where most of the growth arrest would happen. So I think, this patient probably didn't have it, but when I'm putting K-wires, if I'm putting it around that area, I do want to take it off really quick, like, maybe within 4 to 6 weeks, because I'm concerned about, growth arrest, specifically in that area where the hump is.
So I think that is end from my side. I think we'll have concluding remark from Sheetal regarding overall non-union scenario in lower limb, and then we'll get the end of the session.
Yeah, let me share my screen. I'll show you one case, and it's really quick.
Please. I'll take a phone call, Sheetal. Yeah. Please go ahead.
Yeah, that's fine. Okay. Okay, here. Can you see my screen here?
Yes, sir.
Okay, so this is a 14-year-old patient with Down syndrome. I'll just share this case. So this is, ignore the tibial tubercle. The patient had patellar instability, had a tibial tubercle osteotomy at an outside hospital, but just look at the femur. Okay, and if you had this fracture, would you think that this is a good treatment? Any criticism about this? It was a locking plate, periarticular, and 14-year-old trying to spare the physis a little bit. There is some osteopenia, you can see that. But would you predict any issues with this?
Yes, I'm not happy with the reduction which has been achieved at the fracture site.
Okay.
There is an anterior translation of the proximal fragment. And as this has been an open reduction internal fixation, I feel a better sort of a reduction would have been better in this case.
Okay. So the patient, that was the only x-ray I had. I saw the patient one time. Then the patient didn't come because then COVID started. So this was right around that time. And then the next thing I see is a patient came back after 11 months, and he was, probably, if I would have to longitudinally follow this, I'll make sure it goes to Unite before I would allow this patient to bear weight. I think most of you would agree. But this patient, started walking, he was Down syndrome, so compliance was an issue. And then he came back limping. And this is the x-ray when he came back. So like I said, your concerns here, your screw has backed out, you have some lucency around the screws, and you have a non-union, right? And you have a flexion deformity as well on the lateral view. So how would you treat this, or what
Sir,
would you do
inflammatory
next?
markers, sir?
No, they were all normal. He had no symptoms. He was walking on it. He had no pain. He was just limping a bit. But he was, non-verbal as well. He was a Down's patient.
Sir,
But the markers were normal. No fever, normal markers.
rigid
So
fixation, sir. Need
sorry?
longer plate. We need longer plate.
Yeah, but you want to rule out, even though the markers are negative, you want to rule out infection, right? I mean, what else you could have here? Do you think it was a mechanical failure, or it was mechanical and a biological failure? So, my approach is that this is how the patient had, presented. You could see that there is swelling, limp, not able to put the toes down. I got a CT scan. You can see the lucency around the screw heads, all of them. And so we took out the plate, debrided the fracture, did the biopsy, did cultures, put an IFICS on, and put antibiotic cement as a first. My plan was to keep it on for 6 weeks, make sure the field is sterile, and then come back and repeat the plating. But the patient had really bad pin track infection after doing the IFICS. So at 2 weeks, I had to, go back in. This is a post-op x-ray, just taking off everything, and the antibiotic cement there. The cultures did grow strap, but that was from the swab. And the biopsy and all the tissues, they did not grow anything. So I think it was a contaminant. I don't honestly think, even in hindsight, I don't think it was ever infected. But once you have a positive, culture, then you have to treat it. So he was on antibiotics under the care of infectious disease with oral antibiotics. They didn't, he was on doxy for 6 weeks. But 2 weeks after his first surgery, we went in and did this because we had to remove the IFICS because of pin track infection. So we went in and used a blade plate, which is a pretty rigid implant. And then we bone grafted. We used BMP here. And then this is 4 months post-op. Now he has started walking normally. I think it has healed, but we still have to follow him. This is recently. He's 4 months since surgery. I think he's on the right track. And he was looking very comfortable, sitting, walking with a little bit of a limp. But the things that I wanted to share was that, even though your markers are normal and you have no fever, does not mean that you cannot have infection. You can always get low-grade infection. I thought that he was infected based on the pre-op imaging, but since the tissue culture was negative, if I take tissue and if I take swabs, I rely more on the tissue for the culture part of it, since they are from deeper in the fracture side. And he was treated with antibiotics, but that did not stop us from going in and implanting. So if you have a infection, does not mean that you cannot put implants. The fracture can heal in spite of infection if you have stability and you can suppress the infection with antibiotics. So I would recommend that achieve stability, in any form, because if you have infection and you have no stability, then you cannot control the infection. You need stability, and that requires putting hardware in that time. You still have to make the fracture heal. All right, so stop here. And any questions? Anything else?
So the X-ray here, the first X-ray and the implant failure X-ray shows the difference in the joint congruity. Sir. Means the surface, it was the congruity has been changed, sir. Can it be due to the infection?
So no, this patient had pre-existing, previous surgeries, and I would agree with the obliquity, though wasn't a weight-bearing X-ray. But the patient had patellar instability, like a lot of Down's patients have. So he had this osteotomy, a tubercle osteotomy, and what happens with the tubercle osteotomy in a Down's patient, or those who are significantly hyperlax, is that it actually rotates their leg. If there is one downside of doing an osteotomy for patellar instability. And so what happens when you externally rotate the leg is that when you take an X-ray, like we see it, you see the joint obliquity. It's not obliquity because of a deformity of tibia or femur, but it's because it's rotated at the joint surface. So that's something that would correct once you reverse the tubercle osteotomy, which we did in this patient later on. But I just wanted you to know the non-union part of it.
So, Ajmal, you have got a question there?
No, sir.
Please go ahead.
All right, I think it was a great session. There were just great cases, a lot of teaching points, and I appreciate the cases and keeping us involved. And there were really nice questions from the audience, which is always good to hear that you're all engaged. And I hope that you continue with the education and educate others as well. Probably, wherever you practice, you need to make sure that you're always available to help, because you see what happens. Things are not treated in the right way, and if you are, as an orthopedic surgeon, besides treating your patients, is always better to make sure that everyone around, your friends and colleagues, they also do the right thing and refer the patients to you on a timely basis. So
Sir,
I think,
sir, small.
Go ahead.
Sir, small.
Yes, Ram.
Sir, do we have any comparative study between the stimulant and PMMA antibiotic beads, so that less heat was generated from the PMMA when compared to less heat from the stimulant compared to PMMA, which may irritate the physis and the growth arrest? Do we have any study, or we can follow as that the same?
No, but see, every time you have infection very close to physis, right?
Yes, sir.
And if you want to use other thing, I think then you can, yes, you can use that cranioplast, which is a less exothermic reaction compared to this thing. I think stimulant, the best advantage of stimulant is that you don't have to remove it. The disadvantage of cement is that you have to remove it. So the thing is, if you are planning a surgery which requires removal of and revisiting, I think it may be a good idea to use cement. And if you are planning that just local delivery of antibiotic is enough to take care of your sepsis, in those cases, I think best would be to use a stimulant so that you don't have to come back again. Like if you have a gap non-union and you are using a cement spacer, as I and Sheetal showed, that we were very sure that we are going to come back again. In that case, there is no sense wasting money after stimulant. So this is the stability also.
Have you did masculine and pediatric age groups, sir? Masculine technique?
I don't have personal experience of masquerade technique. Sheetal, do you treat?
Yeah, so it's a good it works in kids as well. Especially if you form a little bit of a periosteal sleeve around it, and it does give you good fibrous tissue and enough tissue to work with. So uh, uh, if you're familiar with the technique and you have used it in adults, you can apply it in kids. It does work in children as well.
Okay, sir. And about antibiotic on your experience at local drug delivery system.
Sorry, antibiotic what?
Antibiotic bone cement. Your
I think any heat stable antibiotic can be used, and there's a list of antibiotics available there. I think vancomycin, and I think this meropenem is also heat stable, so you can use that.
Sir, vanco and vancomycin in kids, sir, can they be more nephrotoxic than, or we can use regular dose?
Here there is no much absorption of the drug. So the concentration which is available is more concentrated locally and not in the blood. So I don't think nephrotoxicity is the major issue here. But I think most common antibiotic which we use, vancomycin, I've used cefuroxime on one occasion where vancomycin was resistant. But it is said that even if it is resistant, the amount of
the 300 times more.
It doesn't matter even if it is resistant. Right, Chetan?
The some of the PMMAs come pre-mixed with antibiotics as well. So we also prefer to use vancomycin with the simplex cement. But there is simplex T, which is PMMA with tobramycin. It comes pre-mixed, so you don't have to mix it. The reason that some antibiotics work well is their elution properties are different, and both vancomycin and tobramycin have great properties. So they work well, but you can mix it with the you call it the stimulant. I think you're talking about the calcium sulfate beads.
Yes.
And you can mix them. The issue with that, you have more when they get absorbed, you can still have some drainage, and then it becomes difficult to know whether it's infection drainage or drainage from the absorption of. So if you're using too many of beads, you need to be careful, because then it might just you would be in a difficult spot when it's draining. You wouldn't know whether it's draining because of reaction from the beads getting absorbed versus the infection. The antibiotics are cheap. The only thing is that you have to go back to get them out. So if that's what the plan is you're doing staged procedures, then I think antibiotic cement makes more sense than using anything else. You can check with your suppliers. You have pre-mixed cement as well. You can get.
So I think, Sheetal, if I remember, I think we have only gentamicin mixed cement available. Other, I think we all have to mix.
Okay.
In India, I am not aware of tobramycin, but I'll have to check that since you have said. So gentamicin is definitely available, but other are not available. Okay, I guess.
All right, it was.
Yes, Sheetal.
No, I was just saying thank you, and I'll have to leave. But it was a great session.
Great. Thanks for joining in.
Thank you, sir.
Thank you, sir. So thank you, everybody. I hope you like this fellowship. We would like you to spread the word about the fellowship and more about the knowledge you have gained in this fellowship. The idea is that we educate you, you in turn educate more number of people, and then we have a good level of treatment for pediatrics, that we don't use wrong implants, wrong implant choices. And more so, I think, use the conservative treatment as far as possible, as safely as possible, is the motto of our teaching for pediatric patients.
If possible, conduct a session on osteoarticular infections, pediatric osteoarticular infections.
Okay, so we'll plan that. We have a good collection on that. I think we can come for that. But I think we have one session at VIROC. So if those people who are attending VIROC, we have a good session on that. There's a recorded session going to be there about POSI, with almost all areas being covered in that. So anybody who's joining VIROC should attend that session. Right? So it was really fun having you all with us. We enjoyed fellowship. Hope you had the same experience. And if there's anything, the way we can help you, please write to us. for any case in which you need our guidance. We'll be very happy to help. The help may not come immediately, but within few hours and a day or two, we'll be able to get that.
Sure, sir. Thank you.
Okay, thank you. Good night.
Hello?
Yes.
Sir, it's not related to lower limb. So can I discuss a case with you? I will send you a personal message.
Yeah, please do that. I just need to finish something still pending. So tomorrow you message me and I'll get back to you. Right?
Okay, thank you. Thank you.
Okay. Good night, everybody.
Thank you, sir.
Thank you.